a challenge to dignity. Our goal was to link academics, activists, and agencies concerned with the health of refugees and asylum seekers in a spirit of collaboration and comparison, bringing together professionals working with different populations of forcibly displaced peoples, ethnic groups, and nations. The video you are watching will contain an individual presentation edited to stand alone. We hope you find them to be of value.
Introduce our next speaker, who is Dr. Christine Murto, who is Chief for the California Office of Refugee Health and the California Department of Public Health. And the title of her talk today will be Infectious and Chronic Illness Among Refugees and Asylum Seekers. Dr. Murto, you're on.
Great, thank you so much. Good to be here today. And I hope you all are enjoying the conference.
Yes, we are. We're having a great time.
That's great. I wish I were there with you all. Today I'm going to just give a little overview of, I'm the Chief for the Office of Refugee Health for the state of California. And I'm going to give an overview of infectious and chronic illness in asylum seekers in comparison to refugees. Next slide. So the California Office of Public Health is funded by the Office of Refugee Resettlement, the federal government, to support early detection for infectious and chronic conditions and follow up on conditions identified during an overseas panel physician exam for refugees. And so what we do, it's kind of a safety net. It provides a health assessment within the first 90 days of arrival to the United States. And then after which the eligible populations are paired with a primary care physician. It takes them some time to maybe find a physician and get linked to services. So we provide that interim service. And also it follows the CDC guidelines for domestic refugee screening, which is a little bit more comprehensive than you would get through a regular medical visit. So the populations that are eligible for our programs are newly arriving refugees, those with special immigrant visas, asylum granted cases, victims of trafficking, Cuban Haitian entrants, and most recently, Afghan humanitarian parolees. Next slide. So this is where we provide our services. There's 10 counties. We provide the services through the county public health in county public health jurisdictions throughout California. And these are generally in places where refugee resettlement agencies are located. So the refugee resettlement agencies are working to provide housing and some wraparound case management services. And our counties that participate in the refugee health program are situated primarily in these counties. Next slide. One of the things that's notable when you look at asylees and their access to our programs is that the average time that it takes to access a health assessment once asylum is granted, for refugees, it would be the date of arrival. But it's for asylum granted cases, it's twice as long for asylees and 3 times that of special immigrant visa holders. So asylees traditionally haven't received case management services, so they might not be aware of the health assessment benefit after their asylum has been granted. And so, but the good news is recently California legislature passed the Bill AB 1638, and this provides case management services through California resettlement agencies. So we're hoping that improves this service, because once they're timed out, they after the 90 days, they would no longer be eligible for the service. Next slide. So we did an evaluation of refugee and asylee arrivals to California over the past 5 years. We excluded the special immigrant visa holders from this analysis, and we included Cuban Haitian entrants are included in the asylee category given that they have similar patterns of migration and land entrance for many. So for those eligible for refugee health services in the past 5 years, asylees of working age tend to be slightly older than refugees, and we also tend to see a larger number of children among refugee arrivals. Next slide. So when we look at the countries of origin between who comes to California as a refugee and who comes to California as an asylee, you can see a really vast difference. The refugees primarily have been originating in the past 5 years from the Middle East and the Ukraine, and asylees tend to originate from the Caribbean, China, and Eritrea. So we have to provide culturally sensitive services, we have to take all these things into consideration. Next slide. So this is a map of asylee distribution throughout California. And as you can see, there's a pretty wide range of distribution in counties throughout California. And the red county is Los Angeles County, where there's a larger number of asylees that are resettled. Next slide. So we're going to look at both infectious and chronic health trends and a comparison between refugees and asylees that we did. Go on to the next slide. We'll talk about some specifics. So we look at infectious diseases, specifically hepatitis B and C and latent TB infection. We find that asylees were significantly more likely than refugees and also more likely than the general population in California to have hepatitis B and C, as well as latent TB infection. Next slide. We also find that asylees in California were also significantly more likely to have syphilis, HIV, and chlamydia in comparison to refugees and the California population, although the numbers still remain fairly low for those asylee granted cases. The next slide. So in terms of parasitic infection, which is something that's included in the refugee health exam. You might not go to your physician and be normally tested for parasitic infections, but it's a really important exam especially for children, because it can affect many things in their health and well-being and learning capacity. So our asylees have significantly more likely to have schistosomiasis, but refugees were more likely to have other types of infections of parasites. So in terms of chronic diseases, we see that asylees were actually less likely to have diabetes and hypertension in comparison to refugees, and significantly less likely to be obese in comparison to Californians. We do know that this changes, obesity changes over time, that the longer time people are in the United States, that obesity increases over time. Next slide. So for children, we find that both anemia and elevated blood lead levels, asylee children showed lower prevalence than our refugee arrivals. Where we really typically see elevated blood lead levels is among Afghan children. Actually, see really high level, probably upwards in the neighborhood of 40% of children that are arriving from Afghanistan have elevated blood lead levels. And those children are then referred to their lead control programs, and there's a nurse that works with them and their families. Next slide. So we find also that asylees are somewhat less likely to need updated vaccinations, child immunizations. This is probably because they've been asylum seekers and they may have been in the US prior to the appointment when they come to us, and they would need immunizations for school enrollment. So they may be less likely to need immunizations when they come in. Nonetheless, both groups have been shown to need immunizations. So these programs that are funded through the federal government and access to the refugee health programs throughout the US, actually, they're in all states, play a really important role in updating immunizations in both refugee and asylee children. Next slide. So we've really, in the past year, we've really been doing a lot of work to improve our outreach to the asylee population. Our Office of Refugee Health, in collaboration with USCIS and the San Francisco Refugee Health Program, provides a virtual new asylee orientation. And so this happens once a month, and it outlines the benefits for which asylees are eligible. And then the invitation actually comes through the USCIS office to the newly granted asylee. And then, and it's really been helpful because it comes from USCIS to link the asylee to this program, and so that they can participate and learn what their benefits are. And then through that, we are able to link patients with one of our programs, and where they're living, and if one of our programs aren't in the area that they're living, we link them to a primary care provider. So typically we work with attorneys throughout the state to refer their clients into this program as well, and through refugee forums and other community organizations. And it's been really successful in the past year in making sure that asylees know what their benefits are within that 90 days where they're eligible for a medical screening service. Next slide. The other thing that we've done this past year, we developed a really simple tool that's been distributed through the California Primary Care Association. And this educates physicians on the medical screening requirements for the adjustment to permanent residence status, and also is really following the guidelines of the CDC domestic screening guidelines for newly arriving refugees. Next slide. And you can see on this tool, it's only 2 pages. It really provides information on all of the laboratory tests and immunizations that are required for the I-693 for the adjustment of status, and whether they're for adults or children. Next slide. So as a summary, we find that for infectious conditions, we see that asylees are a little bit more likely to have more complex medical issues in comparison to refugee arrivals. It could be due because refugees have an overseas medical assessment, and many of these conditions may be identified and treated overseas through that panel physician exam. But still, nonetheless, refugees arrive with more chronic conditions. They're arriving from camps, or they're arriving from places where there's conflict. So we look at all of that and treat the patients, or link them with a specialty care provider. So all of this information really helps us to guide clinicians in understanding the conditions that they might want to be aware of when someone comes into their clinic, and also for continued public health awareness, and it also helps to develop disease control strategies. And then in terms of the outreach, we find that the early outreach through the asylee orientation really helps us to educate asylees on the benefits for which they're eligible, and then link them pretty quickly with medical services. And this is our team that's worked on this in collaboration with a UC Irvine collaborators. Just want to thank them as well. Do you have any questions?
Yes, are there any questions for Dr. Murto? When you're sending somebody to a community like PCP, do you send them with information that will educate that PCP about what they might want to look for this particular population? I can imagine that a community PCP might have no idea about any specific concerns.
Yeah, so if it's a patient that we've seen in one of our refugee health programs, we'll send a referral packet to the new primary care provider. If it's a patient that hasn't seen anyone yet and doesn't have a refugee health program in the where they're living, then we send the tool with them to guide the physician in knowing what should be done, because not everyone works with this population and really might not be familiar with comprehensive medical assessment that would benefit the patient.
Yes.
Thanks for your presentation. I know you talked a lot about infectious disease, but I was wondering if you could talk a little bit about NCDs and mental health in the California refugee population, both adults and children. And I was wondering if you could comment on any space for innovation in the state of California with the large numbers of Afghans resettling for prevention services being funded, and especially what is the role of community health workers being potentially involved in that and being a billable service under your state health insurance?
I don't. So in terms of mental health, what we do, we've just switched to this year. So I haven't included this as in our in this information. We're using the RHS 15. It's been a great tool for us. It was developed for refugees, and it's aged for assessing anxiety, depression, and trauma, ages 14 and older. And this has been great for us. Our providers really like it. We find that we're really getting much better information and able to link the patient with care, mental health care easier, because we can identify those conditions. The PHQ, PC, PTSD, and GAD, we're just not providing the type of identifying mental health issues like this tool is. So while I don't have it on the screen, this presentation, this is what we're using. We just have a year's worth of data, so we're hoping that, but we're seeing really good results from it. So I'm really pleased that going forward that we're going to be doing this. We're also looking at resources for children. The evaluations tend to be somewhat longer, and we see patients twice, once to get to do an intake and do blood draws and immunizations, and another for a clinical visit. So it's the children's mental health takes a little bit longer and needs follow up. So we're looking at tools that other refugee health programs are using throughout the state. We also have a physician community advisory panel. We have some physicians that are involved and have made recommendations, and we're reviewing those for use in an asylum seeker program. We have included some ACEs questions in that as well, to see whether that would be appropriate screening for referring further, whether those are sufficient questions. And then you asked about innovation, and especially with our Afghan arrivals. Of course, we know that they are coming in from very traumatic situation. And so there's a lot of really great programs. We just did a full mapping of service providers throughout the state. They could provide culturally sensitive programs for Afghan arrivals. Many of them there's a stigma with Afghan arrivals that for referring them to mental health services, and really where we see a lot of benefits are with those programs that may use a peer counseling model that might be a bridge from the patient to, a higher level provider if that's needed. But it also provides some support. Most of these programs are also the community health workers that are in those programs are trained community health workers. So the Office of Refugee Resettlement, they haven't released it yet, but they're releasing some mental health funding, and we're working to get that into some of these programs throughout the state where in areas where there's a high impact of Afghan arrivals. And so the highest resettlement area is in Sacramento. It's one of the largest resettlement sites for Afghans in the country. And then also San Diego, of course, Stanislaus, and Alameda. So we have 4, and in Los Angeles, we have 5 pretty large areas where we have Afghan resettlement in California.
Great, thank you.
Yeah, sure.
Thank you so much. Are there any other questions?
I have a couple of factual questions that may be too detailed to answer. You mentioned that a large proportion of Afghan children have exposure to lead, and I'm wondering if you have any idea why that's the case. That's my first question. The second one is in terms of origin countries of refugees and asylum seekers. I noticed that Russia appears on both lists, and I'm wondering if you have any sense of what distinguishes Russian refugees from Russian asylum seekers. Are they from different parts of Russia or different social strata? Again, you may or may not know that, but those are things that I'm wondering about from your presentation.
That's a good question. I don't know where, I don't have, in terms of Russia, I don't have the specifics on that. Many times when our refugees come to us, their social strata is the same. They're not coming in. They may have been, had a large house and been wealthy in one country, and they've lost that, and they're they need to apply for benefits. It's an unfortunate reality in terms of but hopefully that helps them then get on their feet and to reestablish as in their resettlement and integration process here in the United States, that helps them. However, in terms of where they're coming from, the regions they're coming from, that's a good question. I haven't really looked at that specifically. We haven't asked about that either. We ask where people are from in order to provide cultural sensitivity, but of course, where they're specifically from usually comes in those personal conversations that maybe a nurse or a doctor is having with them. So, and even an interpreter, if there's language. In terms of the lead in children, this comes from a variety of sources. There's in Afghanistan, they use surma around the eyes of children. So it's like a lead, it's coal that's around the eyes. It's supposed to ward off evil spirits and bad, bad situations and protect the children. And they often have lead in this makeup. That's a big source especially for children. There's other places though as well, other things that have been identified, like spices, toys, paint on toys, or paint on like enamel paints on pots and pans and things like that. So when we identify high lead level in children, we report this. It's reported immediately from the lab up to the state CLIP program, and then down to the counties. And so there's nurses and environmental health specialists that partner together, and they'll go to the homes and they'll evaluate, they'll ask for these specific items so that they can be tested. It's a little scary when, several people come into your home and ask you for some of your things that you've just brought over, and maybe you don't have that much. But we really do give good information, education, how important it is because of the child's lead level. And it's not something that you can, look at a child and see necessarily. So it's also an education about prevention and how important prevention is. Many of our refugees arrive without coming from places where there's prevention because maybe the health systems have been destroyed or they're not very good. And so we do a lot of also education in prevention, what's prevention, and kind of educating them on the systems and why these things are important. Even if you look healthy, there's some things that can affect long term. So, good question.
Thanks.
Thank you so much, Dr. Murto. We appreciate it.